Okay, welcome everyone. Good morning, good afternoon, good night, depending on where you're tuning into. My name is Madalena, or Maddie Conti, you can call me either. I'm a medical student in New York City, and I'll be facilitating today's session. So today we have a very exciting subspecialty VMR focused on clinical reasoning. And we have an incredible guest, Dr. Daniel Restrepo, who will be the case discussant today. So a little bit of introduction. Dan is an internist and clinical educator in the Department of Medicine at Massachusetts General Hospital. He's also a member of the core educator faculty for the residency program and an associate program director for the point of care ultrasound. Some of his interests, but I'll let him share that himself, are medical education, physical diagnosis, point of care ultrasound, clinical reasoning. So Dan, thank you so much for being here. And a question I wanted to ask you before we dive in is if you could share a little bit about how you developed your interest in diagnostic reasoning and specifically point of care ultrasound.
So first off, welcome to everybody. Thank you so much for the invitation, for all the CP Solvers crew. Thanks, Maddie, for helping me discuss this case. And thanks to Dr. Singh for giving us hopefully a fantastic case for today. And good evening, good morning, and good afternoon to everybody else. I'm super excited to be here. So my mentors were all general internists, and they were sort of dyed-in-the-wool diagnosticians that could kind of take a story and examine a person and just figure out what was going on with them. And they were the best teachers, and they were just like bedside clinicians. And it was like so many other times in medicine, it's just like, wow, like that's what I want to be when I grow up. And that's like what I want to emulate. And so diagnosis was always what drove me towards internal medicine. It's sort of like, the thing that wakes me up in the morning outside of teaching. And so that's sort of where I had my interest had always lied with diagnosis, and like, there's nothing against management, but like, I feel like diagnosis is like the coolest part of being an internist. And so that was, and then I got kind of more formally interested in clinical reasoning and the language that we use and sort of the cognitive frameworks that lead to us approaching diagnosis. And with so much that happens in like academic medicine, the stuff with ultrasound is more about like being in the right place at the right time. I was a first year hospitalist before I did my chief residency, and a friend and colleague had just graduated, had finished the emergency ultrasound fellowship at our hospital, and he was looking to train up more medicine docs. And I applied and I learned it. And it's really like, it's from the framework of diagnostic reasoning, it's an augmented physical exam that can just give you so many more data points right then and there at the bedside that you, the patient's doctor, can integrate into their clinical reasoning and into their diagnostic picture. So it was one of these like fortuitous things that then very much aligned with like the things that I cared about as a doctor, which was diagnosis and sort of bedside diagnostics at the bedside.
Amazing. Yeah, we have a little bit of point of care ultrasound at my medical school, and it's been really fun to learn. So definitely a great skill. I was also wondering if you could share something about yourself that you like to do outside of medicine.
Well, I have been getting into wine, which I didn't know could be a hobby. So good for me. And then I love to scuba dive, and I love playing music. So I've been teaching myself how to play the ukulele, which has recently been like the one I've been learning.
Wow, those are all amazing hobbies.
And Rafa, I've been to Rafa's point, I've been learning Portuguese too for a trip.
Portuguese.
Yeah.
Amazing. So our case presenter today probably does not need an introduction, but is the one and only Dr. Ravi Singh. So for people who don't know him, he's a hospitalist and associate program director at Sinai Hospital in Baltimore, and also a CP Solvers team member. Ravi, thank you for presenting a case. For the audience, can you also share with us something you like to do outside of medicine?
Oh, absolutely. Thank you for the kind introduction. A couple of things. I love sports, soccer. I play soccer here and there, but not terribly good at it. Need to run a bit more. I used to play rugby as well, so it was easy to transition over to the NFL. So I do support our local team in Baltimore, the Ravens. And I'm trying my hand at some jiu-jitsu. So I have two kids which who do jiu-jitsu. So I started enrolling in a class while they're training. So a couple of things that I like to do on the side as well as listen to cases and medical education.
Amazing. And last but of course not least, these VMRs can't happen without teaching points and scribing. So I believe Shema will be doing the scribing. Shema, can you introduce yourself and share something that you like to do outside of medicine?
Hi everyone, my name is Shema and I'm a 50 medical student, and outside of medicine I enjoy watching true crime documentaries, spending time with my friends, and yeah, I don't know anything else right now. I have a blackout. I pass the mic.
Amazing. And Andrea, can you also introduce yourself?
Hi, I'm Andrea. I am a Peruvian medical student and a research assistant at Roswell Park in Buffalo, New York. I really like drag and watch a lot of YouTube apart from doing crafts. I'm happy to be here.
Fantastic. Okay, so Shema, I believe you're doing scribing, so you can go ahead and share the screen. And Ravi, whenever you're ready, take it away.
Okay, do we have the whiteboard? Okay, the first part of the case involves a 30-year-old woman who was brought into the emergency room. Initially, she went to an urgent care medical center where they found her to have altered mental status, hypotension, and hyperglycemia. By the time she arrived to the emergency room, she was not able to give a medical history, but her partner who accompanied her stated that she's been dizzy for the last 4 days, also had a decreased appetite and PO intake during the last 4 days, also had nausea, vomiting during this time, and last menstrual period was about 6 weeks ago, and no reported fevers, no diarrhea, no abdominal pain. And I'll stop right there.
Awesome. Great. So this is a great windup. There's like lots of ways to frame this case. There's, I think, plenty of pivot points here. So just in general, whenever I'm approaching a case, I try to find like the simplest sort of symptom or syndrome or clinical problem with the most limited differential diagnosis. And I try to kind of hang my hat or use that as a pivot point upon which I sort of frame the case. Now, there's a few things. We have hyperglycemia, we have hypotension, we have altered mental status. I think it's super useful whenever you're dealing with altered mental status to kind of, as you're crafting a problem representation and trying to couch the tempo of the syndrome, that to me, altered mental status is all about how long. My entire approach to altered mental status is around sort of the tempo. And where it's very helpful is in the acute altered mental status, meaning minutes to hours, and in the chronic. And then we have here, it sounds like now we're hitting about 4 days, coming into a week of altered mental status. We also have a few other things. Before I get to the altered mental status tempo, I often actually pause and ask myself, what are their vitals? This is a do now, act, a do now, think later kind of a situation. And specifically, I ask myself, like, what are any of these vital signs actively explaining the hypotension? The altered mental status. And we haven't gotten an actual set of vitals, so I'm not sure how hypotensive she is, but on first blush, I hear hypotension and altered mental status, and I can't help but kind of relate those two. And then we have another thing, which could be a contributing cause for altered mental status, which is her hyperglycemia. We're hearing hypotension and hyperglycemia. In my mind, often those two are often linked by osmotic diuresis, meaning that if the person is persistently hypoglycemic, they exceed their reabsorption threshold in the proximal tubule, and they all of a sudden have a bunch of free water diuresis that accompanies that sugar, and eventually they get volume contracted. Now, in states like DKA and HHS, that becomes extra counterproductive, because as folks as they get volume contracted, they have their kind of counter-regulatory response with catecholamines and glucagon and things like that, that then worsens the hyperglycemia, that then worsens the volume contraction. And then you see this kind of feed-forward loop take place. We have that she's not eating very much and that she's nauseated and vomiting. And when you hear kind of a young woman, we don't know much of her past medical history, but you're hearing a young woman coming in with symptomatic hyperglycemia, this wouldn't be a bad setup for something like a new presentation of DKA, perhaps in the setting of pregnancy, perhaps from some other stressor that we have yet to identify. This would not be a bad narrative for that. We don't have a medical history on her, so we don't know if she has a prior history of type 1 diabetes. We don't know if, never say never, but especially with the obesity epidemic, we can see type 2 diabetes in this age range, and that could be presenting with HHS. So more to come, I think, from Dr. Singh, but those are my initial thoughts. First off, is the hypotension causing the altered mental status? Is the altered mental status sort of a separate entity, and whatever caused the altered mental status ultimately led to the hypotension? Severe DKA is the first thing that's sort of popping in my head as I think about kind of system 1 processing of like, that's the first thing my brain said before I actually was able to think. So the only other thing that's going to be very important, and I encourage you to ask this question. I've been humbled a lot by severe symptomatic hyperglycemia. And the pearl that I want to leave you guys with, I was taught by a very gray-haired diabetologist. The only question that you really, really, really need to ask, especially in the case of type 2 diabetes, is when you got thirsty, what did you drink? And the amount of times that I've since started asking that question, heard, oh yeah, I started drinking orange juice, or I started drinking, non-diet Coke, is pretty, it's pretty high. And that's a very high yield question is what I would say. And shout out to Dr. Godine, who's the endocrinologist that taught me that when I was the first year attending, working up type 1 diabetes mellitus in a person that I really did not need to work up because he had been drinking orange juice for like, a week when he got thirsty.
Wow. One of the things I'm struck by is kind of your emphasis on tempo when it comes to altered mental status, and how that really kind of changes the differentials that you're thinking of. I'm curious if, say this were more of acute presentation versus chronic, how does that affect kind of your initial management that you think of, and what questions that you ask?
Totally. So I think about the 4 S's of acute altered mental status. And that's, I think, relatively easy to take away. And by acute altered mental status, I mean, like, this person was fine and talking to you, and then a few minutes later, or an hour later, they are unresponsive, or they're not making words, or they're not really making sense. And I think about sort of vascular phenomena. So S is for stroke, seizure, sugar, or substance. So in my head, those are the 4 things that can make somebody go from, totally normal to pretty ill and altered in minutes to hours. And that's when, obviously we frequently cannot ask these questions of the patient, but that's when running the med list, or asking about substance use history, or checking a sugar in pretty much everybody, just it's tough to be humbled by by hypoglycemia. And I've been well into long rapid responses before we thought to get a finger stick blood glucose. And so just don't want to be humbled by hypoglycemia. So in this case, I'm probably worried about the opposite side of that, but those are the big 4. Again, seizure, stroke, substance, and sugar are the big 4 that I think about. So those are the places where I go with like acute changes in mental status. And then chronic changes in mental status, I think, are things like neurodegenerative disorders, which are a little bit slower in how they develop. There's no such thing as acute Alzheimer's. So if, Nana is kind of a little confused, please don't say that it's like, if it happens suddenly, it's not progression of her disease. And then the only other thing, as I would say, is that the psychiatric disorders are in that kind of range, but know that it's your job as the medicine doc to make sure that it's nothing else before you can even start to contemplate a psychiatric disorder. And then the only other thing is that in general, psychiatric disorders are rare to arise de novo in people that are older than, 35, 40. And they're also unlikely to impair sensorium or have kind of fluctuating courses like something like delirium would have. So those are just sort of as I use tempo. And then it leaves us with this, lion's nest that is rat's nest that is subacute altered mental status, because that differential is then, pretty long. Though I would say from Dr. Singh's intro in the STEM part, there are a lot of kind of avenues to chase down with some targeted questions, targeted exam, and some labs that I hope will get in a bit.
Absolutely. Continuing on, past medical history, GERD, hypertension, history of migraines, and kidney stones. She required cystoscopy several years ago. I don't have the exact date when she needed an intervention. Social history, never a smoker, no substance use, no alcohol, walks for exercise, average nutrition, has one sexual partner, currently unemployed and lives with a partner. Family history, mom had diabetes mellitus type 2, also hypertension. Surgical history, abdominal myomectomy, medications, colace, ferrous sulfate, and pantoprazole. Allergies, none. Moving on to physical exam, I'll wait for the scriber. Get ready. Temperature 36.4. Heart rate 120, then up to 160. Blood pressure upon presentation 67/59. Respiratory rate 18. Pulse ox 97%. And then generally, patient appearing ill. Mucous membranes were dry. Heart tachycardic. No murmurs. Lungs were clear. Abdomen soft, mildly distended. Diminished bowel sounds, but no guarding or no pain upon palpation. Extremities, no edema. Neurological exam was difficult to ascertain due to the altered mental status. And skin examination yielded no rashes, no lesions, and I'll stop that right there.
So she's sick, right? This woman is in shock. She has organ dysfunction and hypotension. So I would say that this is one of these let's just go ahead and do now and think later. So that is, again, the first kind of step in how I approach altered mental status. Could any of these vital signs be explaining her altered mentation and her obtundation? And I would say certainly, yeah, a blood pressure of 67/59, even in a previously healthy person can, oftentimes they are pretty well tolerated. But in this case, I would say that she's hypotensive. We need to think about a couple things in a person who may have been pregnant a while ago with a distended belly. We need to think about who may have had her last menstrual period 6 weeks ago. We need to think about an ectopic pregnancy and hemorrhage. We have to add sepsis to that just because she's pretty shocky. So those are like those are certainly things that we have to consider right then and there. I would sort of advocate, as diagnostics are coming back, to have to volume expand her with isotonic crystalloid is where I would start before we go too much into contemplating things. We're gonna get outside of that. We got a lot of information there. It's always great to see a stool softener and oral iron next to each other. I think that those are actively working against each other. That's more of just my own little idiosyncrasy there. But so it looks like not that much, some stuff in the medical history about maybe migraines and kidney stones. She's a little young to have kidney stones. So could this be a signal for a systemic disease? Could this be something like sarcoidosis or IBD that would cause hyperglycemia? Again, an abdominal myomectomy in a woman her age. I've jettisoned a lot of gynecology over the years of being an internist, but that also kind of strikes me as she's being a little bit young for that. So could she have anatomic issues from the myomectomy? Could she have a bowel obstruction in this case, leading to the belly distension? Given that she's had operations and could have some adhesions in her belly from that, does the myomectomy predispose her to having an ectopic? I actually don't know the answer to that question, but those are the few things that are popping out of my head. We haven't really dissected the hyperglycemia, how symptomatic it is. or how bad it is. Does she have an acidosis? Is she in DKA or HHS? Are all questions that I have, but I would hesitate to like think too much about them without seeing how she responds to some volume, as it doesn't strike me that she's profoundly volume overloaded for any reason. I see Dr. Dancel is on the chat, so we could also work in some ultrasound too here, but I wouldn't before I gave her volume and see if fermentation improved. I think that using treatment as test is a pretty powerful tool. And so if you get her blood pressure to 95 and she starts making a lot more sense, I think that that's a good test of using treatment as test there. But I think we're gonna get a little bit more data. I'd love to see how she does with a better blood pressure. I think as we're drawing labs, thinking about, again, a hemoglobin, which may be falsely reassuring if she's acutely bleeding. You know, I think a bedside ultrasound is possibly useful. I think the other thing that I'm thinking about is, you know, blood cultures, basic metabolic panel to assess whether or not she's in DKA, and a pregnancy test would be super useful too.
I actually had a quick question about, oh, sorry, Ravi. I just had a quick question before the next LQAT. So I think what the point you mentioned about, you know, treatment before diagnosis here when someone's this sick is really important. And you talked about kind of giving her fluids to see how she responds. I'm curious, say, you know, you gave her fluids and she did respond versus didn't. How would that affect kind of your diagnostic reasoning based on her response to the fluids?
Yeah, I think that's a great question, Maddie. I would say that I think we could refine the lens of what we're worried about diagnostically. I guess in my mind, diagnostically, the question is she altered because of something else, or is she altered because she's hypoperfusing? And the best way I can see to answer that question is to increase her cardiac output by giving her crystalloid right now. And if fermentation improves with a better blood pressure, I would at least I'd feel a little bit better that I have the time to think about all the other things that could that are going on with her. I think on one point. The other point I would say is that if she, excuse me, sorry, if her blood pressure gets better and her mental status doesn't, then that makes me really need to think about, you know, what is causing this encephalopathy, because it's not hypoperfusion. That's sort of how I'm thinking about it right
now. Got it. That makes a lot of sense. Ravi, go ahead.
Okay, I'll give you the labs next. So sodium was 135. Potassium was 5. Chloride 98. Bicarb 15.7. BUN 37. Creatinine 3.27, baseline is around 1. Glucose 475. Anion gap around 19. Albumin 3.1. Calcium 7.2. Alkaline phosphatase 432. AST 225. ALT 219, total bili 0.9, lipase 20, magnesium 1.9. Lactate went through a progression from 4 to 6 to 8.1. And then CBC, white count 21.55. Hemoglobin 8.8, MCV 82, platelets 209, INR 1.5, PTT 39.4, and pregnancy test was negative. And I'll stop right there. And then there's 2 more aliquots before we have the final DX.
Okay. So Dr. Singh, may I ask any interventions surrounding that lactic acid?
Sure. So fluids were given with a temporary increase in the blood pressures, and as soon as the fluids were given, the blood pressure did improve and then started dropping again. And again, the second bolus was given, and then for a while the blood pressure stayed high up, and then again dropped down again. And then through that progression, the lactate, instead of coming down or reversing, started getting worse. So it went from about 4 to 6 to 8.
Okay, and her mentation when she
slightly, I don't have that information, but what I do remember was there was a slight improvement in the mental status.
Okay, great. So one point that is sort of just kicking around in my head is her pulse pressure. So if you take her systolic blood pressure and you subtract her diastolic blood pressure, her pulse pressure is I suck at math, but it's 8, which is tiny. And you may recall or may not recall, which is I'd never really thought about pulse pressures a lot till I was well into my residency. But it's a surrogate for stroke volume, right? The delta in blood pressure that occurs in systole is proportional to the size of the stroke volume. And if you have wide pulse pressures with hypotension, that often can signify that you're in more of a distributive state. And if you have very narrow pulse pressures, that can often suggest things like cardiogenic shock or profound hypovolemic shock. Now, Dr. C, may I ask for baseline hemoglobin? Are we privy to that? Because she's pretty anemic.
I don't have that information. Sorry.
Okay. So as I'm seeing this, what can we glean from the labs? So she has acute kidney injury, she has acute liver injury, she has acute brain injury, and she has evidence of sort of significant hypoperfusion. So this is shock. The question is this distributive? Is this anaphylactic? Is this obstructive? Is this cardiogenic? Is this hypovolemic? Is this hemorrhagic? We can dissect, I think we can be pretty sort of intellectual about the acute kidney injury and the acute liver injury and all these other things. But I am just very worried that we're dealing with incipient shock that's just developing in front of our eyes. The concerning thing is that it's shock that didn't really improve with fluid, which in my mind makes me think about profound hemorrhage that we're not really keeping up with, and her degree of anemia would make you think that maybe we're missing some belly hemorrhage with that distended belly that she has. The other things that makes me worry about are actually sort of occult cardiogenic shock. So here she's hypotensive, but just a good pearl that I've learned over the years of seeing kind of cardiogenic shock sneak by me several times has been that blood pressure does not equal perfusion. Here it does. She's hypotensive, and we have evidence of diffuse organ damage and sort of a lactic acidosis, but I've seen plenty of normotensive cardiogenic shock. And it's often manifesting with progressive lactic acidosis and organ and visceral congestion, but their blood pressure can remain pretty normal for a long time. So I do have to throw kind of cardiogenic obstructive shock on the list here as well. I think for sure she needs, this is a person that my hospital does not have that many ICU beds, and so we end up taking care of super sick people on the floor, but this is somebody that I would strongly advocate gets put in an intensive care unit. This is somebody that I think probably will need vasopressor support and should have dedicated imaging of her belly. I think a CT without contrast of her belly would be super useful here. One, it would be able to tell you that with this history of nephrolithiasis that she has, does she have stones that are causing obstructive acute kidney injury? I think do we have a urinalysis in this case?
Yeah, I'll give you the next aliquot.
Okay, all right. So we're gonna have to, obviously I'm a big fan of the kidneys. They're the brains of the body, and I'm one of the single most important diagnostic tests in the approach to AKI is going to be the urinalysis that we're still holding out on. And then the only last question is that she has a significant leukocytosis. Again, this could just be a stress reaction to all of things that are going on to her. but is this sepsis? So I do think that, blood cultures should be drawn in this case. The other thing I'll two more things to touch on. One is the sugar. All you really need to have DKA is to be a diabetic, to have ketones, and to have an acidosis. She has a gap of 19. Interestingly, that probably is constituted. There's plenty of lactic acid there to explain that. The UA may show you ketones, which standard urinalyses look for acetoacetate. And the major ketone in DKA is actually beta hydroxybutyrate. So in these cases, measuring a beta hydroxybutyrate could be useful, but the sugar, just like the white count, could just be a big stressor or a response to this very, very, very sick woman. Could it mean that she has an underlying occult diabetes? That's certainly another possibility. And lastly, the acute liver injury is probably a mixed versus a hepatocellular liver injury. That alk-phos is pretty high. The Billy is not that high. So this could be, stones, this could be sludging from sepsis, this could be a lot of things. I feel like I'm reaching for a lot of stuff just because she's pretty sick, and there's several different parts of the case that you don't want to leave unresolved or unaddressed, but doing it in real time is often, you're kind of sort of trying to see what you can piece together. What do other people think? Maddie, how about you?
Yeah, I think something that stood out to me is, right, we mentioned the vitals, and also when I saw the vitals, it's like, okay, it's pretty clearly that there's shock here, and we got confirmation of that when we're seeing end organ damage, when the liver, the kidney, etc. And I, like you, was trying to go through, the buckets I have in my mental model of shock, whether it's obstructive, distributed, etc. But I am having a hard time figuring out if we know enough information at this point to prioritize one of those types of shocks. And it was interesting to hear from your perspective, the pulse pressure. I had never heard of that as a way to, not hang your hat on a specific type of shock, but maybe prioritize that more. So I think at this point, I think there's just a lot more information we need before we can reason further. So I think getting imaging is really important here. I'm trying to look at the chat to see. Shema said multi-organ dysfunction and sepsis, liver enzymes elevated, ultramental status, kidney injury, etc. Yeah, so those are my thoughts.
The only other thing is that she has,
yeah,
just to get excited, because and Ravi, this was in Baltimore.
Yes.
So the one thing to think about, I don't know how much time she's spending around rats, but this could be leptospirosis, right? So whenever you see mixed AKI with significant liver injury, they're often icteric. Often on exam, they have sort of what's called a conjunctival suffusion of very, very, very red, angry eyes. Can think about things like leptospira. So leptospirosis can make people super duper sick. And then that is Weil's disease, as was said there. And there's often a myopathy that's associated with it. Their CK can be pretty high. And interestingly, they can be kind of hypokalemic in these settings. But that is more, again, that's one that you want to call when the person's doing well. This is more of a do now, think later. So to sum this up, obviously I want this urinalysis. I would like some blood cultures. I think I would love to get some imaging of at least her belly with a non-contrasted CT to start out, to see, is there blood in the RP? Is there blood in the peritoneum? Does she have obstructive nephropathy as evidenced by hydronephrosis due to stones or some other process in the pelvis? Could this be DKA, getting a beta hydroxybutyrate and looking for urinalysis, ketones in the urinalysis? If you see the ketones there, that could be helpful. It doesn't necessarily seal the deal. And yeah, that lactate and those blood pressures that are unresponsive to fluids are concerning me. And just a quick plug for POCUS. The other thing is that in shock, I believe Dr. Dansel may have said, obviously looking for free fluid in the belly is very quick to do. I think in this case, an evaluation for LV function and RV, looking for RV dilation on a focused cardiac ultrasound could be super useful here. Yeah. So yeah, if you have a good pump and you have an RV to LV that's adequate, those are strong points to say that maybe she's underfilled and that we still need to give her a lot more resuscitation.
Yeah. I'm just looking in the chat, and Ala mentioned, she said, if lipase wasn't normal, I think pancreatitis would tie in the labs. I just wanted to pose that to you. How do you think of lipase? Off the top of my head, I don't know the sensitivity and specificity of that, but are you considering pancreatitis in this case, or does the lipase kind of cause you to deprioritize that?
That's a great question. So it's about 80% sensitive. So you can miss 1 in 5 cases of acute pancreatitis. We typically talk about 3. We talked about 3 sort of central criterions in the diagnosis of acute pancreatitis. One is a lipase more than 3 times the upper limit of normal. The other is a sort of characteristic abdominal pain syndrome, classically described as, many say, searing or stabbing pain in the epigastrium that goes to the back. Often I have a lot of patients who give me sort of like a pantomiming band-like pain over the epigastrium. And then lastly is imaging evidence of pancreatitis. So again, a CT could technically tip you into the diagnosis of acute pancreatitis in this case. You can frequently have acute, you can have a leukocytosis. It is an inflammatory process. And then if the pancreatitis has been going on for long enough, you can have multi-organ dysfunction syndrome with sort of anasarca. You can have pleural effusions. You can have acute kidney injury from systemic inflammation. If she did have a gallstone there, that could give you the alkaline phosphatase and all the other stuff too. So yeah, I think that thinking about pancreatitis is a great idea. It's an awesome point. I will say that when the pancreatitis has been as bad, like so bad that folks are this sick from it, it's usually lipase positive and very positive, unless it's chronic pancreatitis that like totally burnt out. That's more experiential. I don't really have data to back that up. I'd be curious if any other seasoned clinicians on here have seen sort of a case of pancreatitis this bad that would be lipase negative. I personally have not.
Amazing discussion. Robbie, do you want to move on to the next aliquot?
Sure. Yeah, I also want to add, I've never seen a lipase negative pancreatitis, but you never know. So the urine analysis had a hazy appearance, large heme, large leukocyte esterase, +2 protein, specific gravity 1.018, bacteria many, squames 35, and urine WBC was 221. Hemoglobin A1C 15.3. The urine WBC 221. Hemoglobin A1C 15.3. EKG showed sinus tachycardia. Normal QTC. And the X-ray showed borderline cardiac enlargement. There was something that looked like air under the diaphragm. Lungs were clear and expanded. Right-sided lower lobe looked like an infiltrate, possible pleural effusion, blunting of the CP angle on the right side. Left side was normal. And there's one more aliquot, which will reveal the final diagnosis.
Okay. So, Dr. Singh, were there actually red blood cells there, or just the white cells called?
There were 10 red blood cells.
Okay. So, a few things we see here. We got a lot of white cells out of proportion to the red cells. You have protein. In the presence of acute kidney injury, that should always make you think about glomerulonephritis. Or acute interstitial nephritis. This is a potentially inflammatory sediment. Eventually it'd be useful to kind of take a look at the shape of the white blood cells. Are they in casts? Are the red cells dysmorphic? Are the red cells in casts? But I still just don't get that sort of a flavor from it. Her hemoglobin A1C is 15%. So this is diagnostic of symptomatic diabetes in many ways. The question that I now have kind of is, does a history of kind of probably a new diagnosis of advanced or poorly controlled diabetes, I don't want to say poorly controlled as a judgment to the patient, but rather just diabetes that's not been intervened upon, it changes her as a host? And the answer is yes. It probably means that she's profoundly volume contracted from being hyperglycemic for some time. One. Two, she has some degree of immunosuppression, so she could probably mask large sort of inflammatory insults that other people would be a lot sicker from. And the thing that I would be worried about is sepsis in this case, partly because she's shocky. She's not that much better with fluids. So I do think that we have to think about sepsis on one point. That could be sepsis from a urinary source based on that urinalysis. The other thing is when you look at the chest x-ray, she appears to have air under the diaphragm. So she's got this distended belly and she's super duper sick. This is the other thing that this is very concerning for, is a perforated viscus, which kind of comes back to the question of, can we get a CT scan on this woman once we get her a teensy bit more stable? Just so that I don't kind of lock in on too many things, looks like that there's possibly some enlargement of the cardiac silhouette. There's that air under the diaphragm. I don't really know what to make of the right-sided lower lobe or possible. Those were on the same side, the blunting and the infiltrate.
Correct.
Outside of it, to say that many times you can have what are called sympathetic pleural effusions. So it just seems like she's got all these belly symptoms. She's been vomiting. She's not been eating. We have air under the diaphragm. She has a distended abdomen. She has a very, very high lactic acid. This could be sort of all reactive to what's going on in the belly. So again, I'm worried about an intra-abdominal catastrophe in the setting of poorly controlled diabetes, plus minus, some symptomatic hyperglycemia and some sepsis. Those are the things that are going through my head. I'm trying to think if there's anything else that I could comment on or that I'm missing here. Maddie, what do you think?
Yeah, I think I'm struck by the protein in the urine and trying to tie, because let's see, I mean, we have esterase, we have protein, we have red blood cells. So to me, that's a picture of glomerulonephritis, as you said, and I'm trying to connect that with the shock picture that she's having and how those two are related, which I'm not, and with the elevated hemoglobin A1C. So I think there's, these three things that I'm tracking, and I'm not entirely sure how they're all related. And so I'm not exactly sure here, but I think we definitely need further imaging, especially given the X-ray showing air under the diaphragm. As you said, that's really concerning for potential perforation. So I think she definitely needs a CT scan once she's more stable. And then I guess the question to you is, what other interventions would you do here before more testing?
So I think that there's enough here that it's worth kind of empirically covering for a urinary tract infection and sepsis from a urinary source, given that there is sort of diagnostic equipoise. I think obviously that cardiac enlargement, again, back to Ria's point earlier, is I think the point that we made earlier, just to take a quick look at her heart, I think is using doing some focused cardiac ultrasound would be one thing that I'd be reaching for in somebody that's this sick. What else do I think? I think getting her blood pressure to a place where she's a little bit more stable with vasopressors, maybe blood products. I'd be thinking about surgical consultation. She's just pretty sick, and I'm pretty worried about her. She's sick and she's undifferentiated, which is like the danger zone, because you're kind of wondering what levers to pull in this case. The other thing to think about is that could she just have an obstructed stone that's causing sort of sepsis of the urinary source, given her prior history of nephrolithiasis. And I've certainly seen people come in incredibly sick, which wouldn't explain the air under the diaphragm, but certainly folks with advanced diabetes are at risk for things like Klebsiella and other sort of severe gram-negative infections in the urine. So back to the blood cultures, but starting treatment with tailored towards gram-negative rods up front would probably be a thing that I'd start doing. Vasopressors, antibiotics, based on what we could see on exam or on ultrasound augmented exam, you could think about more crystalloid to try to sort of see if she is still volume responsive or not.
And then one last question I had is, oh, go ahead.
Oh yeah, and to Rafa's point, I mean, it's an A1C of 15. We don't really know when the last time it was done. This certainly could be diabetic nephropathy, explaining the proteinuria. It's just really tough to say in somebody that's, I typically don't think of GN as or even interstitial nephritis as things that present with shock. And so I can't disentangle the fact that she has multi-organ dysfunction with the fact that she has clear sort of undifferentiated shock at this point in time. That's kind of where my brain is sort of wrestling around this. You'll catch me on the wards and I will be saying, don't ever ignore GN, don't ever ignore AIN, but those folks are almost always hypertensive. So it just strikes me as sort of tough to disentangle from everything that we're seeing here. And she's so dang sick.
Yeah. And does her lack of fever affect your reasoning at this point at all?
Does her lack of fever affect my reasoning? I would say if she didn't have an A1C of 15, a younger person like this is a lot more likely to give you a fever with a severe infection. Once we get above the age of 65, about 30 to 50% of people with bacteremia won't have a fever. So I think that the A1C of 15 really changes her as a host, right? This is a person with chronic hyperglycemia, impaired phagocytosis, impaired neutrophil function, things that like make her, we often say immunosuppressed. So I'm just going to put immunosuppressed in quotations. So to me, it's not a differentiator in her as a host.
Got it. That makes sense.
I'm curious to hear what other people think before we learn too much more. I feel like I'm just sort of treading water here.
Ria mentioned pelvic exam, question mark. Do you think could that be useful in this case?
I think certainly it could. It's not something that I do frequently in the setting of shock, but in a young woman, I think it's totally, if there's a lot of blood in the vaginal vault or a lot of cervical motion tenderness, I think that those could be very useful diagnostically. Got to say, I should be doing them more often. Do we usually crowdsource the problem representation?
We can go either way if you want to propose one or anyone in the chat does.
I think I've been talking too much.
We can give it a few seconds to see if anyone in the chat wants to throw one in there. I mean, I'm happy to try one, but Dan, go ahead.
All right. Well, how about you try one and I'll try one. Okay.
So we know the problem representation involves, the who, the what, the when. So I would say that this is a 30-year-old female with a history of hypertension and found with a hemoglobin A1C of 15%, presenting with a subacute altered mental status. It's been how many days? 4 days. So subacute presentation of altered mental status, hypotension, and hyperglycemia, found to be severely hypotensive to the 60s over 50s with multi-system organ dysfunction, including the liver and the kidneys, and a urinalysis concerning for glomerulonephritis.
Okay. There's a lot of very good stuff.
There's a lot of stuff there.
So I would say that this is a 30-year-old woman with long-standing hyperglycemia and occult diabetes mellitus, presenting with acute changes in mental status and undifferentiated shock with concern for an intra-abdominal process versus a genitourinary process. So my wish list would be blood cultures, urine cultures, and a CT of the belly. Pretty, please.
Definitely, I'll give you the CT, but you're doing a remarkable job, Dr. Restrepo. Definitely that narrow pulse pressure got me. This was a case that was presented to me this morning. So it's like fresh off the press. And I really honed in on that. And I was glad to hear that you exactly focused in on that. And that was pretty much a center of what you thought was going on, especially with possible shock, sepsis, whether it be the whole spectrum. You sort of ran through the whole spectrum of shock there.
And the only other thing to add to that is, I think, because we haven't mentioned it yet, is a PE. And you know, that's just one of these. It's going to be hard to test for. It's going to be hard to disprove. But you know, there's a lot that's happening here. But I do think that has to get thrown up there, especially with the narrow pulse pressure and the tachycardia. Even without hypoxemia, even with the mild tachypnea that she has, it does have to we have to kick it around in our heads. And another reason that I think, as I was getting that CT scan, I'd be thinking about doing focused cardiac ultrasound.
Awesome. Yeah, I'll give you that as well. In regards to Madeline's question about the temperature, this presentation was in a matter of hours. So she did eventually, hours into her presentation, have a temperature of 39 degrees centigrade. And then she started manifesting with rigors. CT was done, and there was gallbladder wall thickening, pericholecystic fluid or sludge, moderate collections of air and fluid in the retroperitoneum and free interperitoneal air, a stone in the lower pole of the right kidney with gas formation in the lower pole, in the lower pole of the right kidney, a distended bladder with gas in the bladder, left renal edema with punctate stones, mild left hydronephrosis, distension of the left ureter, mild stranding, and a 4 by 4 millimeter stone distal left ureter, minimal ascites, severe constipation, and a moderate hiatal hernia measuring about 5 by 6 centimeters. And
wow.
I'll give you the final diagnosis after this.
Wow. Okay. So this is very useful. So as I mentioned, the gnarly things that can happen when you have longstanding diabetes in your belly include emphysematous at an organ. So you can get emphysematous cholecystitis, you can get emphysematous cystitis, emphysematous pyelonephritis. So at emphysematous, and it's usually from sort of flora that have had enough time to rapidly reproduce and create gas. So you often think about anaerobes as causing gas, but really any rapidly dividing organism can produce gas. And so what do we have? We have some gallbladder wall thickening and sludge. Looks like free intraperitoneal air. And then we got stones all over her kidney with bladder distension. And so my money here is if I was going to lock in on something, I would say that the gallbladder is probably fake news. You know, folks with sepsis sludge a lot. That's probably what's causing the acute liver, the aminotransferases and the high alkaline phosphatase. And I think that the money is really here is actually in her urinary tract. Whether sort of the thing that's tough to kind of reconcile is where did that free air come from in the actual, did the gallbladder cause that? That's just strange. Do we ever get a re-exam on was she actually tender there?
Because of the alt-mental status, she wasn't able to elicit tenderness.
So I still think the money is in the urine. This sounds like a case of emphysematous pyelonephritis. The most common organism is Klebsiella, though E. coli can cause it too. And sometimes these are really actually tough to treat. Sometimes they actually do require nephrectomy. And I just don't know where this gas is coming from in her belly. That's the stuff that's sort of there was no other note of a perforated viscus anywhere else in the actual lumen, Dr. Singh?
No. So the thought was that the emphysematous pyelonephritis possibly ruptured into the peritoneal cavity, causing that gas.
That's a striking amount of gas, right? Like when you look at these scans, there's just pockets of little gas within them. That would have to be a striking amount of emphysematous pyelonephritis for there to be like a rim enough for you to catch it on something as insensitive as a chest radiograph. That's fascinating. This is a wild case. And the test of choice would be blood cultures, which are, with the presence of Rigers in this clinical syndrome, highly predictive of actual gram-negative rod bacteremia. So the urinalysis could be polymicrobial too, though I'd venture a guess that E. coli or Klebsiella are in that urine. Sometimes other gram-negative rods as well are possible to cause this. And the preamble here is, again, chronic hyperglycemia and glycosuria is thought to be a lot of the predisposing factors in this illness script. And also, so those stones have to come out, or she's not going to get better.
Definitely. So regarding the course, so she had that fever and the Rigers, and that also prompted me to think about gram-negative rod bacteremia. Started on broad spectrum antibiotics, taken to ICU, of course, just like you had mentioned earlier on. Urology performed a cystoscopy, and a large amount of pus was drained once the wire was forced through the right urethral orifice. She did suffer shock and PA arrest, and unfortunately, during this struggle, she did end up passing away. They had performed ACLS for about 25 minutes. A POCUS was performed, and she had markedly decreased myocardial contractility, no pericardial effusion, normal RV size. So unfortunately, it was quite a long battle in the ICU with maximal pressor support with epinephrine, phenylephrine, and giving multiple doses, also norepinephrine. But unfortunately, she succumbed to this devastating illness.
That's so sad. It's a bad diagnosis. They're very, very difficult to treat. And as in this case, they can get pretty sick. When you think about her, I think at first blush with her one-liner, you would never really think about her as a vulnerable host. But the more you kind of peel back, you can just see that she was probably walking a tightrope for a long time with an A1C of 15. And my sense is that she probably had occult non-localizing symptoms for some time. She may have had a septic cardiomyopathy in the setting of all this inflammation going on. And so that's just so sad. But she, it's just really hard to localize symptoms in the presence of chronic hyperglycemia. And I think that may have been the case here.
I just want to make a comment about the gallbladder findings. You're right on about that's just noise and not really signal. So that initially did, as part of the thinking or approach to the case, they were thinking maybe it's a gallbladder issue, but definitely that can be a red herring. There's this extrarenal manifestations of acute pyelonephritis. There was ascites, pleural effusion, all the stuff in the lung cavity also was a lot of noise or extra renal manifestations, is pleural effusion, gallbladder wall thickening, and sometimes you can get hepatic periportal tracking. All of that could be just an extension of the adjacent inflammation. This was very interesting, though, that that EPN can rupture and cause this amount of gas manifesting as pneumoperitoneum. And you're right on the money with the stone being the cause of all of this, and then the amount of pus or purulent material building up behind it. So appreciate all the walkthrough for the case. Thanks.
May I ask what it grew on culture? Do we know?
Yeah, the cultures were still in the lab. I don't have to follow up with the cultures.
This is so hot off the press. Okay.
Oh yeah, Robbie, I am blown away by your case presentation, and it's really, really heartbreaking, the outcome of this patient, that you presented in such an amazing way. And I know we all learned so much. I learned so much here. And Dan, your discussion was truly incredible, even from the beginning, when you have all these different chief concerns and trying to figure out which one to prioritize and hang your hat on. So thank you for that. Before we jump to teaching points, I wanted to pass the mic to you, Dan, to hear any reflections you have on this case and on the reasoning process.
It was tough. I think that there's lots of ways that this case could have gone, right? As I was sort of seeing it unfold, is this DKA? And to me, the thing that like blew me away is how sick she was. And so the entirety of the case stopped being about thinking and started being about doing. And when you have a young person that's that sick, I mean, you end up doing now and thinking later. And so I really felt a lot of the reality of being kind of down in the ED and like sort of jumping on this very sick, very undifferentiated person. And I really felt that. It's not like, this isn't like a nice, discrete sort of clinical problem. This is shock in somebody and that shock is causing multiple problems. And so it felt a lot less elegant, and it felt more like we just need this information so that we can get to this point, and then we can start thinking about like, what is this? But like, we need to find like these 5 things that could kill her or that are killing her instantly. And there was equipoise between them. So this was like, there was a big sense of urgency here, I think, as I was discussing it, picturing how sick she was, and unfortunately that this awful illness led to her demise. It's very sad.
Well, thank you for that. Andrea, can you take us away with teaching points?
Sure, a very sad case for sure. So we started with altered mental status, and it's important to differentiate how long does the patient have it, if it is acute versus chronic. We think about the S when we think about acute altered mental status, like seizures, sugar, substance, or stroke. And chronic, you will think a neurodegenerative disease or a psychiatric disease. It's unlikely to appear in patients older than 35. And also you have to make sure it's nothing medical before ruling that it's a psychiatric disease. The osmotic diuresis is like a phenomenon where the hyperglycemia produces hypotension due to loss of water. Normally, when we think about hyperosmolar hyperglycemic state, we think about more type 1 diabetes, but they can also present in patients with type 2 diabetes. A question to ask that you should not forget to ask in diabetes mellitus: what do you drink when you get thirsty? And they would say orange juice or Coke, the one that has sugar. Because the patient presented with organ dysfunction and hypotension, you should do now, so do in that moment, which was they give isotonic crystalloid and think later, because you need to make sure the patient is not in danger of dying. The patient had a distended abdomen, and we found it can be due to their abdominal myomectomy, because it can produce adhesions or an ectopic pregnancy. And also we can think about bowel obstruction. The pulse pressure, that is the systolic minus the diastolic pressure, is a surrogate to straight volume. And because the patient have low pulse pressure, it could be due to cardiogenic shock, distributive shock. And something that is important to remind ourselves is that blood pressure does not equal perfusion. The principal product of diabetic ketoacidosis is beta-hydroxybutyrate that you can measure, because this patient is from Baltimore. We talk about leptospirosis. It presents with myopathy, red, angry eyes, and hypokalemia. And a review of the 3 diagnostic criteria for acute pancreatitis is lipasa more than 3 times, normal limit, characteristic pain, like sharp stabbing that goes to the back, and imaging evidence. There is this thing called sympathetic pleural effusion that is reactive to what's going on. It's not what causes the problem. Something to remember is the patient's age, 65 or older, and any other immunocompromised person will have bacteremia without fever. Any rapid dividing organism can produce gas, not only anaerobics, and can produce this phenomenon in symptomatosis. And normally Rigo is a high predictor of anaerobic bacteria. Thank you very much.
Andrea, those were incredible teaching points. Thank you so much for going through that. And thank you, Dan. Thank you, Ravi. Thank you, everyone, for coming. And I know we all learned so much. I definitely did. So thanks, everyone.
Thanks, everybody. Thanks for having me. This was a blast. Appreciate it.
Take care.